to the Health Coach Impact Podcast, the official podcast of HCANSA, the Health Coach Association of Australia and New Zealand. I'm Sharon Curtain, Director of Accredited Health Coaching Australia, and I'm also on the board of HCANSA. In this episode, I'm joined by Associate Professor of Lifestyle Medicine at Southern Cross University, John Stevens, and we're going to be talking about the power of shared medical appointments. Very excited to have you on, John.
Thanks, Sharon. Great to be part of it.
Now, would you mind introducing yourself and talking a little bit about your journey to SMAs?
Sure. So my name is John Stevens. I'm an Associate Professor of Lifestyle Medicine at Southern Cross University. I've been a registered nurse since 1983. I've been an academic since 1990 and teaching in a whole variety of health disciplines. So I guess my journey to how I came to be on your show came from being a nurse, seeing people not aging very well. So I'd go from ward to ward. I'd see a lot of young, old people sick with a lot of chronic illness. It was before the chronic illness epidemic that we now know was kind of, well documented. But I was seeing it in real time on the wards that I was working in. And it really challenged me as to why this was happening. Why were so many people coming in ill? It led me to, I did my PhD in sociology, trying to find out about this very topic. It led me to academia, and in my research days at academia, I was looking at aging well. How do we help people age well through various mechanisms of health promotion? But then I ran into a fellow called Gary Egger who was coming up with this notion in Australia called lifestyle medicine. And that clicked for me. Absolutely. That was lifestyle medicine looks at, it's not only aging well, it really is the scientific evidence-based action, if you like, towards aging well, which looks at 6 pillars: nutrition, physical activity, substance misuse and abuse management, and sleep, stress management, and connection to people and to nature. And there I found my calling, if you like, about 20 years ago. So we started this movement, I guess, which is now a worldwide movement called lifestyle medicine. And what we realised is a lot of clinicians already practice lifestyle medicine. They already have good practice and knowledge of how to deliver or how to inform their patients about eating better, moving more, stressing less, sleeping better, etc. So that concept was not new, but the package was new, and the way we used the evidence base towards it was new. But what was difficult for clinicians is the ability to actually practice that in a short, sharp, time-limited consultation. And most of our health systems around the world are short-based consultations led. It's unusual to have anything else. And we realise the clinicians were feeding back to us very clearly that, we want to tell our patients more and help them change their behaviour in a whole range of areas. But we just don't have time in 10 or 15-minute consultations, right? And so Gary and I saw shared medical appointments, a version of it being enacted over in the States through this hospital called Cleveland Clinic, people might have heard of. They were doing shared medical appointments in their clinics as a way of doing outpatient and inpatient clinics rather than one-on-one consultations, and as a way of being more efficient and peer supportive. And it was just so obvious that this was something we could bring back to Australia and work on here, and help clinicians find another model of care, if you like, to deliver enough information to help their patients change behaviour, if you like. So for the last 15 years or so, I've been banging on about shared medical appointments for a very long time, and you can see my flat head from banging it against brick walls, because people go, what? 15 patients in a room? No way, it's never going to happen, right? And so we've been battling the culture, I guess, of not wanting to change. Lots of people really interested in it. Lots of people doing it now probably have trained over 2,000 clinicians in how to do shared medical appointments. And we're here now and it's starting to take off. You can feel the momentum shifting as people realise the benefits that come from this. It's not the only thing they have to do. I mean, you still do your one-on-one consultations if that's what's required. But for those patients who can benefit from a shared medical appointment, there's a world of benefits in there that I can describe if you like.
Yeah, look, I would love you to tell us more about shared medical appointments. I mean, it's I think a lot of health professionals feel similar to you. They feel like the model that we have doesn't work. We're repeating ourselves over and over again, saying the same things to the same people. Where we're trying to talk about lifestyle. We're wanting to bring up those concepts of even just exercise and nutrition, let alone stress management and social connection. But everybody realizes and acknowledges that they're so powerful and they need to be talked about, but the model isn't there. And I think that is what's so exciting about shared medical appointments is it is this exciting new way of practicing, not that new, but new to a lot of people. And it's got all of these incredible aspects that make it so effective. So I'd love you to talk a bit about that.
Yeah, sure. Look, I'm very biased, so you're getting my opinion, not only the evidence, but my opinion about what I've seen. Having done this for 15 years and actually been involved in developing practices, especially primary healthcare practices, develop the skills and the ability to integrate this into practice. I've seen lots of different examples of it. And we have the saying, if you've seen one shared medical appointment, you've only seen one, because they're all very, very different. But I guess they start from a premise that there is going to be, they are individual consultations, whether they're medical or other allied health provider consultations. We use the word shared medical appointment here in Australia because we want to use the medical benefits scheme whenever we can, wherever it's appropriate and legal. But you might see it written in other literature as group appointments, group interventions, group consultations. In Aboriginal health, they call many different names depending on your location. They call it medical yarn up, seeing the doctor together. In East Arnhem Land, they call it medical dawu dawu, the story of the story behind your medical condition. So you'll see many different versions of it, but it's basically the same thing. It's individual consultation carried out sequentially. That is, everybody in the room, in the circle, will get a one-on-one consultation with the provider. It's led by a skilled facilitator, and that'll bring us to talking about coaching in a minute. And the provider, whether that's a GP or other allied health person. And in my university, we're starting to use it widely now in naturopathic consultations as well. But the trick is we have other people in the room listening and participating. That is, other patients with similar concerns listening and engaging in it. A good number is somewhere between 8 and 15 patients or participants. And the minimum team is your provider and a facilitator. You can have others, you can have translators, you can have spouses, you can have other allied health with specialist knowledge coming in depending on how you want to use them. But the trick is that everyone, and the difference between this and group education is that everyone is getting their one-on-one consultation as if they had come and seen the clinician individually. That why would they come to see the clinician today? For whatever their reason, and they're going to have that consultation. Now there's a whole lot of background work, and we train all that, train people in how to manage all that and prepare it all so that you've got consents and privacy issues sorted and billing sorted. All that's part of the training of what we do to prepare and integrate into practice. But the end result is that imagine you have 10 or 15 patients in a room with chronic illness. Diabetes is a very common one. They all have different reasons for seeing the doctor today, but they have one, or the provider that day, but they have one thing in common: they have type 2 diabetes, right? And it might be very varied what they're coming to see the GP about, but it's most likely going to be about something related to the diabetes. And so the consultation takes place between the clinician and the patient, but everyone else is listening. Why? Because they probably have the same questions. They probably have the same condition, or know somebody that has, or have worries about their future as that condition progresses, etc. And it becomes this amazing tapestry of experiences and stories and knowledge transfer that just can't happen in a one-on-one consultation. It's very empowering for the patients, very empowering for the clinicians that are in the room as well, to get a lot more out of that hour and a half that you would spend with those patients than you would in a 10 or 20 minute time limit one-on-one consultation. And what we find is the evidence is just overwhelming. There's thousands, literally I've seen clocked 5,000 peer-reviewed evidence-based articles about shared medical appointments. I haven't read them all, so don't test me on that one. But I've seen them. Read a lot of them. And they come up, there's five or so common things that keep coming up. That they improve the patient experience. About 98% of patients say they prefer shared medical appointments for their chronic disease management than any other way of doing it. They love it. The clinician well-being is improved because, like you just said, they don't have to repeat themselves again and again and again on the same topic area, same patients, right? They get a lot more joy out of the interaction they have because, sorry, what I didn't mention in the description of a shared medical appointment is that it's a longer time period, right? We're an hour to 90 minutes, depending on how you design it and what you want to get out of it. But it's a longer time with your patients. Now, even though there's more patients, you're still exchanging all that wonderful stuff that you do in a group, right? So the clinicians get a lot more out of it. We've had many clinicians tell us that this has saved their careers, that they felt that they were lost and their careers were wasted because they just weren't making a difference, just repeating themselves, and they were sick of the 10-minute hamster wheel that they were on. And then they've discovered shared medical appointments. They've gone, bang, my career has been saved. There's just numerous conversations I've had with clinicians about that. It improves the outcomes are there. The health outcomes are there and measurable. That it improves health outcomes compared to standard care in a lot of chronic disease conditions. It actually reduces costs for the practices that actually engage in it, and they do it well and they do it efficiently. They can actually improve their income and reduce their expenditure overall. It takes a little bit of upfront investment, like a lot of these things do, in times and energy to sort of get things organised with your staff and resources. But once you do, you can imagine you're seeing 10 patients in an hour or 90 minutes. You can't do that in one-on-one consultation time, or if you do, you're doing it very, very. It's unlikely that you're doing it well, and with any degree of satisfaction for yourself or your patients. And what probably, from my point of view, what it does is it produces the opportunity for clinicians to provide more equitable healthcare. That is, we can put more resources into helping people prevent and manage their chronic disease with lifestyle and other interventions. And the scene, if you like, provides safe access for people. People feel better about coming, especially in marginalised groups and underserved groups. They feel empowered. They feel less anxious about coming into the group and well supported. And the overwhelming evidence is, patients leave feeling supported. They have peer review. They have peer support and information that they gain from other patients, not just the GP or the provider. So it's out there that the evidence is good, and why aren't we adopting it everywhere? That is my question to the world. Why aren't we doing it everywhere? I mean, you don't want to do it exclusively. You still want to do your private stuff with private stuff one-on-one. But when it's chronic disease and when the patients are up for it and agreeing and consenting, and you do it once and you see the benefits of it, you think, why aren't we doing this all the time everywhere? And that's a good question. I'd like someone to answer it for me. Yeah.
And I suppose the first time I heard shared medical appointments, I pictured a group education session where everyone gets access to the doctor. And then when I learnt more, and it wasn't that, um, you know, that's where I got really, really excited about this as a new model that should be everywhere because there is connection. People don't feel alone. They feel heard. The question that they might have felt was foolish to ask, someone else is going to have asked. Or the information that they missed when the doctor told them at some point gets explained to them again. And they go, oh, that isn't even how I understood it the first
Yeah.
time round. So, like you said, they get an hour and a half of, in general, I find doctors and most health professionals are really good at talking about concepts. They're really good at explaining, how diabetes affects your body or how the foods you eat impact your blood sugar levels. But when you've got a consultation and you're throwing all of that information at someone, they don't really get to take it in. And so this feels like it's almost more chunked and
Yep.
more digestible when it's done this way as well.
Look, so true, and that feedback comes back all the time. Look, there's some evidence out there that shows that about 80%, if you're on a one-on-one consultation in normal primary care arrangements, that about 80% of what is exchanged in that consultation is lost by the time you're home. So you don't remember it. And look, I kind of know what I'm talking about. I've been doing this work for ages. If I'm sitting having a one-on-one consultation with my health professional, I'm sitting there wondering, oh, if I ask this, am I going to be an idiot? Am I going to sound really silly? And I'm thinking about the question rather than actually listening. And I'm guilty of it. I walk out thinking, well, why didn't I ask that? Like I get home and that question I really wanted asked to answered, I haven't even asked. So, people who aren't health literate or are as health literate, I can't even imagine how they navigate a one-on-one consultation in a time-pressured situation.
Mm.
Yeah.
And it's the questions you don't think to ask that someone else asks.
Yes, and that comes back a lot. We've got one beautiful. There's a couple of great stories, I guess. One of them, the very first one we did in Australia was about 2015 in Mullumbimby, my hometown, and we'd run a few of these for patients who were type 2 diabetes, but their health literacy wasn't so good. So the GP was really keen to have his own patients, about 10 of them, in a room and doing these one-on-one, doing the shared medical appointment. And he'd known these patients for a very long time. And so we're going around the room, and they're doing their consultations with him one-on-one with everyone else listening. He's come to this woman who's known for like 15 years as his patient. And she's saying, look, I'm really having trouble sleeping. I've always had trouble sleeping and blah, blah, blah. And the patient sitting next to her knows her socially and says, but Mary, is your husband not driving the soft drink van round town delivering soft drinks everywhere? She says yes. And this is the patient asking the patient, right? So the patient's taken over the consultation. Doesn't he get a lot of cola drinks for free as part of his job? Yes. And the doctor goes, oh my gosh, the penny drops for him. How many colas do you drink? I've got to be careful not to use the brand. And she said, oh, I haven't really thought about it. And she starts calculating, her eyes go up to the left, and she goes, oh, 40? She said, 40? Yeah, 40 a week? 40 cans of cola a week? And everyone in the room, all the patients go, oh my God, and including this woman was not unintelligent. She was a librarian, right? She knew stuff about stuff. She just never put it together. And the GP says, you never told me you drink 40 cans of cola a week. And she says, you never asked me. you know. Anyway, she puts it all together, and of course, she's diabetic, can't lose weight, having trouble losing weight, no sleep, blah blah blah, and immediately goes home and changes her whole behaviour just on that one issue, and goes cold turkey on her cola drinks from her husband, and comes back 2 weeks later when we have the next session and says, oh my God, she's lost kilos, she's eating better, she's sleeping better. Something like that would never have come out in a one-on-one consultation, I guess. It was like one of the very first times the lights just went on for me, like, how good is this? So,
Yeah. I also think, like when you're time pressured, you're seeing your GP, you really do just kind of ask those sort of questions. Your GP asks what they've got to ask, you answer. You might have a couple of things that you want to ask. But I can imagine in this group medical appointment where you've got someone maybe asking a question and talking about something, and then there's people going, hang on, I drink coffee in the afternoon.
well, it's
Oh,
right. It spawns the whole thing, and other people say, "Oh my gosh, I've always known that cola was probably not a great drink for diabetics." And then the GP goes, "Yes, and why?" And so it allows the GP to sort of bounce responses off as well, right? So,
yeah. And I can imagine there's more of a sense of, feeling a bit of a laugh, a feeling to say
hysterical.
something that you might not say in a more formal setting.
hmm That is definitely the case. Like when the group is comfortable with each other, and it doesn't take long. It's amazing how quickly they bond when they realise they're all in there with the same issues ish, and they bond very, very quickly. And the laughter and the stories and the jokes and the mistakes that they make and they talk about are fantastic, and really, all part of the great tapestry of what happens in a shared medical appointment. But can I say that probably there's two main differences from group education. One is that it's still a one-on-one consultation that everyone gets to listen to, right? But two, it's run, the real leaders, if you like, within the shared medical appointment are the facilitators. And the facilitator can be anybody from another GP to a allied health person to a peer person to someone who's just good in the community, depending on what it is you've designed your shared medical appointment to do and be. The thing that the facilitator does not only manage the space and make sure that the mood and the the etiquette, if you like, of the meeting is undertaken, but they are often in a really good position to be coaching. So where the provider will give advice, the facilitator has this ability to add a layer of information and this is where the coaching side of things can come in. And I've seen facilitators, especially when we do what we call program shared medical appointments, where we often invest a curriculum into shared medical appointments like weight loss or anxiety reduction or depression management, or pick a topic and we can do a program in it over a series of shared medical appointments. The facilitators then often become incredibly well positioned to be health coaching, as well as delivering good information and supporting the meeting with the provider. And that's what brings us back to you and the sort of skills that we would love facilitators to have, which are the health coaching skills, and the providers too, for that matter.
Absolutely. So the health coaches have a skill set which aligns beautifully with facilitation. And it's about the drawing out of wisdom from the group. So, like
Yep.
you said, not the impartation of information and not the advice giving, but, who else has struggled with this? And what strategies worked for you? And what did you take away from this? That drawing out and the implementation, particularly if it's a program, how would you implement this? And what have been your barriers? So that really and that then facilitates the discussion and the sharing of the
Look, it's the perfect skill blend for that scenario. It really is. I mean, health coaching works well in any situation, but I see the skill facilitators that have health coaching either innately within them or have done your courses, and it's chalk and cheese between just running a meeting or really capturing the energy and the vibrance of a really good shared medical appointment.
yeah.
So I recommend all the people that I train in how to do shared medical appointments. We introduce them to the topics of coaching, but I do push them towards yourself to do more if they really want to expand that skill. I think it's really important.
I mean, what an opportunity for health coaches, to be part of. There's a lot of there are health professionals who are health coaches, and there are health coaches who don't have any health professional training apart from what you have to do to become a health coach. But it doesn't really matter, because once you're in that role of being a health coach, you your skill set is pulling the wisdom out of the group. It's not about sharing expertise. And so, it's this fantastic opportunity for health professionals everywhere to start pulling health coaches into their consultation structure, and letting the health coaches be the ones that support the implementation of that information.
Wouldn't that be a perfect scenario, perfect world? And you know what? If we got that implemented, the efficiencies and effectiveness of especially chronic management, chronic disease management and prevention would just go through the roof. And I mean, we see this wave of chronicity coming, that which, when you read the economics of what's happening with chronic disease, it's quite frightening. Chronic illness, just diabetes alone, if left to run its course, this is in the United States, and we follow them in terms of a lot of our metabolic illness. Just diabetes alone by 2035 will completely bankrupt the American health budget. 2035, it's only 7 or 8 years away, because of the rise in numbers and the cost of keeping people well, just with diabetes, let alone any other chronic disease. And it's a trend worldwide. Chronic illness, often lifestyle related, and now often lifestyle and environment related, is really going to test the current systems. And if we don't find solutions, and this is definitely a solution that's positive and it's not ripping anybody off or making anything worse or giving you less, you're actually getting more money for your, more bang for your buck, as they would say, by doing it this way. And we have to find models of care like this in order to sustain healthcare into the future. And I'd welcome more people doing this, and not because I've been studying it or whatever, or not because I'm selling anything, but just because I've seen it and believe it.
Yeah, and I think, as health professionals, we want the best for our patients. We want them to thrive. We don't want their, medical conditions to deteriorate. We want them to improve. And, I think it's got to be a change in mindset. The one-on-one is not the most effective use of resources.
No.
In fact, running a group with this, still getting the individual attention that they need, but harnessing that wisdom and getting that connection and understanding and opening up. This is a way of actually getting to, and particularly some of those hard to reach groups who aren't as health literate.
Well, isn't that true? And and in a lot of communities, especially I've been working in Northern Territory and other Aboriginal health services, the one-on-one consultation is in fact not a safe place for a lot of underserved communities. Aboriginal health, immigrant health, and other underserved groups. Sometimes that one-on-one consultation is inaccessible. It's not safe. And we're finding, especially in Aboriginal communities in Northern Territory, for example, a lot of the communities we're working there have really decent health clinics provided by the health services up there, and they'll have an 80% no-show rate because, 80% of the time people are booked in, and 80% of the time they don't show. And that's an incredible waste of a resource, and it's a sign that the community is not engaging. And when you do the research on it, you see that they're not safe, because going to a clinic is where all the bad things happen in their lives. That's where kids were taken away. That's where people died. That's where things happen they culturally don't understand. We still have this expectation that people understand simple biological mechanisms in the Western way. Like I think I was mentioning to you about one community I was with, where their understanding of how the heart pumps we understand how the heart pumps blood around the body, and that the basis of heart disease is that if your heart stops pumping blood and you die, right? So heart disease is still the biggest killer in Australia, ultimately. And you try to explain that to some of the communities out there. Well, the heart is the blood is pumped and the heart beats because of the spirit of the community of country. Country is responsible for how my heart is beating and whether my blood is flowing, not some drug or some other thing going on. So there's conceptual differences that are still really quite remote in understanding of what our understanding is. And it doesn't mean their understanding is wrong. Absolutely, it's a beautiful understanding of how the body works in relationship to the country they live in. But to try and translate that, I mean, why would you come into a clinic if you think, hey, this is a doctor here who thinks my heart pumps blood around? What an idiot. He's got no idea. The spirit from the country is what's keeping me going here. He doesn't understand that. Where's he coming from? Like, really put it in perspective, and it's really obvious why they won't come to the clinic. Anyway, shared medical appointment has been a really great vehicle to help the clinics bridge the gap with the communities, so they can come together outside of the clinic. You can have these shared medical appointments as we have in recreation centres, under trees, in creek beds, fishing on the beach. Like, it doesn't have to be restricted to be within the clinic. You can have them anywhere and still have the principle of it, a one-on-one consultation with everyone listening and joining in, and it can be in a non-threatening way. So it's provided a really fabulous vehicle for a change, a decolonisation, if you like, in Aboriginal health of the health services, so that they can meet the community needs at a more equitable level. And you see that happening, you see how powerful that is. Suddenly those clinics that were getting an 80% no-show rate now have a 100% show rate, because they'll have their shared medical appointment. The trust is gained again with the clinicians and the service, and now their one-on-one consultations will be taken up as well, whereas before they just wouldn't go because they didn't feel safe. So it's a real bridge builder as well.
And I imagine it's capturing a lot of people who, well, one weren't going with a 80% no-show rate, but potentially it would be capturing people earlier in the community as well.
Yep, because the conversation is allowed to happen. Like, we're not hiding it and we're not scared of it anymore. So, and the clinicians now, because they establish a very different relationship with the community, rather than walled in their clinic with their white coat and their stethoscope around their neck, they're now having to go out into the community and be as vulnerable as the patients are, in terms of being on their own without the protection of the clinic around them, and they have a different empathy for what's going on in the community than sitting well protected in their nice, fine, clean clinics. Yeah. And they get to see why, recommending good nutrition, right? Pillar of lifestyle medicine. Good nutrition will help your metabolic health, but then they get out of the clinic and sit in the community and they realise there is no fresh food. There is no fresh vegetables. The only stuff they got is what's at the local shop, which gets refreshed every, once a week when the barge comes in. And, that access isn't what we think it could be. So you start to get an understanding of the determinants of health aren't quite what we imagine they are in some of these communities. Yeah.
And there's a role in, in talking with you in the past, there's a real role for that bridge between the clinician and the group, isn't there? Like an Aboriginal health worker or someone who's connected to the community.
Yeah, and that works in any environment. So I guess we teach, because we're teaching clinicians how to do shared medical appointments and lifestyle medicine. So we come at it from a fairly traditional Western style of understanding, I guess, and transmission of language and ideas. But the bridge, as you say, is right. It doesn't have to be a clinician that's the facilitator, or you can have a facilitator who's a clinician and a community person in the room who's translating, like the translators in East Arnhem Land will sit in with the clinicians and literally translate those concepts I was just talking about before, the difference between way Yolngu might think heart works to the Western version, and I'll try and navigate what that can mean, you know, and it makes such a difference, and it brings confidence to the patients and a different understanding to the clinician, which is just wonderful. The learning, they call it two-way learning, and that's what it becomes, and that's something in itself. That, you know, that's the breakdown of that power relationship that is part of the problem of the one-on-one consultation, the one that makes me sit there thinking, am I an idiot? You know, what's the question I'm asking? It's because it's that unintended power relationship that occurs, right? But the shared medical appointment breaks that right down and offers the opportunity for the clinicians to learn just as much as the patients, you know, in that two-way interaction. It's really good. It's outstanding. And I guess the Aboriginal health is an extreme version of that, but it happens in non-Aboriginal settings as well. But I've always believed that if we can learn how to manage the health of the most marginalised people in this country, then all the lessons are there for everybody else. Because you can always find a resource to treat the Macquarie Street in Sydney sort of person who can go to one of those specialists. But the real lessons on how to care for people and how to talk and exchange knowledge on health, especially at the most marginalised areas, is where all those lessons are that we all need. So, you know, that expression that came out of COVID, if we're not well till we're all well. Well, it's kind of that's kind of a really true underpinning that sort of drives the shared medical appointment idea too.
Yeah. And I mean, it's a different group, right? I've got elderly parents and I watch what they take from medical appointments. You know, when I sort of was thinking about this interview with you and the shared medical appointments, I was thinking how powerful it would be even for groups like that.
Yeah.
Who, you know, talk about the different walkers that they've got, and they talk about
exactly,
you know, how they navigate getting to the shops, and they talk about, I don't understand this part of the services, and you know, like you said,
who sells that cheaper than somebody else? And
yeah. I got my walker from the op shop. Oh,
exactly. That happens all the time, and it's a wonderful thing. And when a lot of patients say no, that'll never happen. You'll never get me in a group. You know, I can never talk in a group, and sure, and that's fine. You're not going to convince everybody to join it. And a lot of people say, you'll never get me talking, opening up in a group, and they get in the group, and 5 seconds later you can't shut them up. You've got to be a really good facilitator to quieten them down, you know, because they suddenly realise how empowering that scenario is, and they've got a lot to say because they've got a lot of experience.
Yeah. Once people feel connected, they feel comfortable, and as you said before, safe.
So true. And there's lots of ways to do shared medical appointment. Connection is a really good point. Like we talk about social prescribing and social connection as a really important pillar, and it is. And it's another shared medical appointments are another way of bringing people together with common issues that can feel supported and peer supported. The amount of times people end up going for coffee or starting walking groups or, you know, reading groups or, you know, cooking groups that have come from shared medical appointment, fishing groups, Northern Territory. All these guys now go fishing together, you know, because of shared medical appointments. It breeds the potential for a good social connection and nature connection, because we've got some doctors that actually take people walking in nature as part of their medical consultation. So while they're walking in the bush and enjoying the beautiful of nature bathing, they'll have their one-on-one consultation in that moment, right? And everyone's still listening, and they're walking and talking their health. For mental health, that's a winner. What a way to do your mental health. Walking in a forest, doing your consultations in a group that way, winner.
Anywhere a group sitting in a garden, you know,
Exactly.
What a beautiful way of talking about health. What an apt environment.
And some of these things are defined by the financial model that needs to be built into this, so that it's sustainable for the practice or the service. and that's part of the training, if you like, is designing the shared medical appointment to fit your local needs and your financial model. And sometimes they're full fee paying and you charge a lot for them, and sometimes they're full Medicare and you can charge Medicare. Sometimes they're free because the service is paying for it. Like there's the whole range of, and online. So what I haven't mentioned is they're fantastic online. So we're experimenting in remote areas now with doing online shared medical appointments, telehealth, rather than one-on-one telehealth with a group, right? In the same model, just on telehealth, or hybrid. So you can have people in a room, you can have a specialist in Melbourne, you can have their GP in Darwin, and a peer support worker or a translator in a remote community out 250 kilometres west of Alice Springs, and they're having a shared medical appointment with their GP in Darwin and the specialist diabetes endocrinologist in Melbourne, and it all works, and it works financially as well.
Yeah.
Yeah.
So before we move on to talking about how you get trained in it, can you, for the people who are watching this and not just listening, can you tell me a bit about the background behind you, which is
I thought you'd never ask. Well, it's really hard. I don't know how to sort of lean out of the way. But this is, well, love it or hate it, this is an AI generated image of shared medical appointments. I described shared medical appointments to AI in Australia and what we try to get out of it with that quintuple aim that I mentioned before. And it came up with this, and I just thought, wow, that's spectacular. It's multicultural, it's embracing the 6 pillars. There's food and activity and nature in there and whatever. Anyway, so that's my it's going to be, looks like my halo almost, doesn't it?
Yeah, a little halo of people.
A little halo of shared medical appointment halo.
Yeah.
So yeah, my wife is an artist, and she hates AI images because she reckons it's going to ruin humanity and destroy the world. So I don't show it to her.
Yeah. Well, I would love to see the one that your wife comes up with.
Yeah, she hasn't done it yet, right? So
Yeah.
exactly.
Well, you can have that as your background once it's finished.
Until she comes up with a better one, this is it.
So there, from talking to people who've run shared medical appointments, the thing that I know is it's not something that you just do. You don't just say, oh, I'm just going to put a flyer up, we'll get a group together and we'll just run a shared medical appointment. Like there are things that you need to know to make them successful, and training that you need.
Yeah, look, and thank you for pointing that out, because I've made this sound like a very easy, joyous process that happens like that, because I get so excited by it. But you're right. If your first shared medical appointment is a failure, that'll be it. You won't have another one, and the place where you work won't want another one. All right. So yes, there is training, and through the Australasian Society of Lifestyle Medicine, through Southern Cross Uni, there's other places starting to offer it now. There's at least, if all else fails, there's a couple of toolkits around. One from the Brisbane South Primary Health Network. If you go onto their website, you'll see a toolkit which we've had a hand in writing, which sort of lays it out for you. But even that, if you're trying to cook a dish and you use a recipe, sometimes it takes more than one go to get it right? So, and you don't want to get it wrong. So I would recommend not sort of giving this a go without having some good support around it, because the design is everything. The training of the process we use is to integrate is we orientate all of stuff. If the whole of practice doesn't come on board, it's not going to work. You need everybody from reception to all the clinicians to the management all agreeing that this is what you want to do. It then requires specific training for the specific clinicians or facilitators that you're going to have, and we offer that, and more we're going to be offering more health coaching as part of the facilitator skills development, and then I offer the services to help you integrate that into practice, working with your practice manager, and you might have a finance manager to work out the model that works best for each practice. And unfortunately, there's no one size fits all. It is a bespoke type of arrangement because not only is every shared medical appointment different, but every practice is different in terms of what their needs are, what their patient groups are, the sort of income they require to be sustainable. And so, yeah, it's worth finding a professional like myself, I guess. There's not too many of us out there yet, but I'm hoping to change all that, and with some of the developments we're doing at the moment, to have more people becoming trainers. Yeah, I wouldn't recommend doing it on your own without some support to begin.
Yeah, it sounds simple. It's a bit like health coaching, right? It sounds simple, and then you try to do it, and it's like, oh, this is actually a bit more nuanced than I realized.
Yes, and it is actually conceptually very simple. I mean,
Mm.
it's a group consultation with a doctor or a clinician, but yeah, everything else that goes around it is if you don't get it right, you'll get it wrong, and then you won't do it again. Yeah.
Yeah.
Mm.
So, in summary, group medical, shared medical appointments benefit the patients.
Yep.
Good attendance rates, no more 80% DNA rates. Clinicians love them. There's two-way learning. Um, they can be financially viable, and it comes down to the training of the people who are running it, really, in how successful, and the logistics of setting it up
Correct.
can make these things run really well, and they're beautiful. No matter what your population group is, a shared medical appointment is a model that benefits any group, and particularly those marginalized groups where you've got the person who can make it relevant and interpret it from a Western way to a culturally appropriate way.
I've in 15 years, I've never seen a shared medical appointment that didn't work for any group that was offered yet. Where I've seen them not work is because we didn't prepare properly. There was things out of our control. Sure, I mean, you're going to have sessions that just don't work, and patients not turn up for whatever reason. In East Arnhem, we had patients not turning up. We're sitting there waiting in the rec centre, waiting for 15 patients to turn up to talk about their diabetes, and waiting. No one turned up. We thought, oh dear. And then the driver came in and said, no one's coming today. There's water buffalo in the main street, and no one can get out their front door. And you go, well, that doesn't happen in Sydney. So, so yeah, things happen. But in terms of we've yet to find a group or a medical or a health condition that doesn't fit a shared medical appointment. There's bound to be some out there, but I haven't found them yet. And really, if you set it up and design it well, and people are trained well, then there's no reason it shouldn't work.
Yeah. Um, so there's training out there. You can do it through ASLM, you can do it through yourself. There's other providers, there's toolkits, which I'll link to. And I think we've got to rethink the models that we practice under if we want to reverse or even stop, you know, go upstream, stop dealing with all the people at the bottom of the waterfall, really making that change to change the trajectory of people with chronic disease. We need new models, and I love shared medical appointments as a, we've just said it's not that easy to implement, but essentially an easy to implement model that everybody.
Well, once you set it up, it's easy.
Yeah.
It's the setup, like everything,
Yeah.
and takes some thinking about. But once you've got them going, they're so easy.
So easy and so practical.
Mm-hmm.
Yeah. Thank you for your time, John. We
A
will
pleasure.
link to ways that people can connect with you. And for those of you who are listening, if you would like to train as a health coach, head over to the Health Coaching Association website. We've got approved courses. If you want to work with a health coach, we've got a list of health coaches who are accredited. Always look for an accredited health and wellness coach. And we've also got, obviously, the opportunity, if you're already a health coach, to become a member. So become a member and join a community of engaged and really well-trained health professionals. or new. I call health coaches the new health professional. And, from this chat, I hope that you can see the opportunity for using health coaches in a new way in shared medical appointments or training yourself in those health coaching skills. So thanks again for listening. We look forward to our next exciting installment of the Health Coach Impact podcast.
Thanks for listening to Health Coach Impact. If you enjoyed today's conversation, please subscribe, share, and leave us a review. It helps us support more coaches just like you. Stay connected with Ekanza on social media, Facebook, LinkedIn, and in our YouTube channel. If you want to learn more about membership and resources, go to our website www.ekanza.org. Until next time, keep learning, keep growing, and keep making an impact.